Thank you, Dr. Mahapatra, and our organization for giving me this very important, seminar on hypertension. What I'm going to do for the next 10 minutes is how to dissect out the multiple hypertension guideline. And as you see here in the slide, the target is, like a moving target, like it's like a pendulum is moving. But at the end of 10 minutes, I will impress on you that this pendulum is going to stop and give us a very clear cutoff what is the current in 2021, how we should treat hypertension. Of course, as the chairperson said, multiple guideline, and I will mention during this, during my talk. Let us see the new guideline. What does it say? All the guideline agree to the principal areas of emphasis on accuracy of BP measurement. As a matter of fact, BP measurement is very fundamental, as Dr. Ponde as well as Dr. Manoria addressed in their earlier talk. Cardiovascular risk assessment is important regarding the BP treatment threshold. Lifestyle modification is recommended and initial combo therapy. So all the guidelines, these are the areas where there is a clear-cut agreement. So there's no difference of opinion. However, these are the 4 areas what I'm going to discuss in the classification of hypertension, threshold, what is the treatment goal and what is the treatment strategy. Is there any difference among all the guidelines? Now coming to the classification, we know the first one which made a lot of difference, like a sort of noise in the among the clinician is the AHA-ACC 2017 saying more than 130 to 139 diastolic 80 to 89 as the stage 1 hypertension, which is also to some extent, little bit now sort of, the global, the International Society of Hypertension, which again puts stage 1 and 2 only, unlike the European, Indian, and even the NICE guideline, or for that matter, even the Canadian guideline saying 3 grades, 1 to 3, and they've classified normal, optimal, normal, high normal, whereas here normal, elevated, etc. So basically the AHA saying more than 130 as the stage 1, and that is the difference among the guideline between the AHA and 2018 European, that European saying more than 142, 159, diastole 92, 99 as the grade 1 hypertension, then grade 2, grade 3 accordingly, whereas the American guidelines saying stage 1 hypertension when the systolic blood pressure is 130 to 139 and diastolic 80 to 89. Now, this is what the International Society of Hypertension 2020, which is published in about May month, and the practice guideline telling us the normal blood pressure less than 130/85, high normal, what Americans said stage 1, and 2 grades only in this particular ISH, unlike the European and the Indian guideline, where there are 3 grades between 140 to 159 and 90 to 99 as a grade 1 hypertension. Now, Indian guidelines also more or less are going to the same thing, suggesting the optimal, normal, and high normal, more or less the same as the European counterpart, as well as the maybe the NICE guideline, etc. Now, if you have to look at the important the reading, what you should know, particularly since Dr. Ponde highlighted the value of ambulatory and home BP monitoring, what is the reading between the office, ambulatory, home, you say is the hypertension. Office BP of 140/90 is equal to home BP of 135/85, and also the daytime mean of ambulatory 135/85. So remember, roughly 5 millimeter less than the office is the home BP as well as the daytime mean. Whereas a night BP, if it is more than 120 systolic and more than 70 diastolic, is considered as an hypertensive. And if it's a 24 mean is a 130/80. So these figures we need to know, because these figures will put, the diagnosis of whether, like, are you based your reading on the office or on the basis of home. This particular slide was shown by Ponde regarding the hypertension guideline, the Canada. Basically, they are given importance to diabetes. If there is a diabetes, whether it is automated or non-automated, more than 130/80, they consider as an hypertension. In a non-diabetic, the automated more than 135/85 or a non-automated 140/90. So they are given about 5 millimeter difference between the non-automated and automated. And some people believe even 5 to 10 difference may be there between the home and the office. Very, very important slide. In fact, if all delegates understand this, I think I've done the job, because the theme of World Hypertension Day 2020 is to take measurement of blood pressure very, very properly. Take the blood pressure measurement properly, control it properly, and live longer. And that is the theme. This is also highlighted by my previous speaker, my friend Dr. Ponde. And this is what all important, like how we are supporting the back, how the cuff is tied, how the patient is resting his foot, whether it's the automated or whether it's the mercury manual auscultator, should be quiet room and relax for 3 to 5 minutes. Take 3 readings. The first we can sort of discard, and the later 2 measurements at an interval of 1 minute, and so on. Very, very important. It may look like fundamental, but to me, hypertension, you make or break everything on the basis of your reading. And if you are going by the office BP, is more important. So just to summarize, in the diagnosis of hypertension, the difference between the guideline is that all the guideline tells more than 140 to 90 as the stage 1 or grade 1 hypertension, except for the AHA, that is 130/80. But when it comes to the risk, more than 130/80 by all the guidelines. So essentially the message in the diagnosis, you look at the risk of the patient and then say whether more than 140 or more than 130 as the stage 1 or a grade 1 hypertension. Let us go to the threshold for the treatment initiation. Again, the European and the American go by, again, the whether high normal or the grade 1 hypertension. Therapeutic lifestyle is important, but when more than 130/80, if you've got a high risk like coronary artery disease, CKD, stroke patient, you will intervene. And if not, go according to the indication, like you start therapy. This is also same by Hypertension Canada, saying that for low risk, more than 160/100 is the threshold, and the target, again, which we'll discuss in the next part of our talk. And the high risk, like the patient who has got the atherosclerotic cardiovascular disease more than 15 to 20% at the end of 10 years, more than 130 is the threshold. So also in a diabetes, 130 is the threshold. So basically, again, highlighting the fact, Indian guideline also suggesting the threshold for blood pressure depends upon the risk of the patient. So second important message, that treatment initiation means at what stage you are going to start the treatment, again, depends upon what is the risk of the patient. So again, coming to the previous one, diagnosis based on the CV risk, whether stage 1 or grade 1. Threshold for BP again depend on the risk, like general population more than 140/90, high risk more than 130/80. So both diagnosis and the threshold remain the same figure, 140/90 and 130/80. Now let us come to the treatment goal. Treatment goal is again, depends upon whether age less than 65. This is according to the European guideline and the AHA. Again, making AHA very simple for everyone, 130/80 or so. Whereas, European probably CKD, CAD, maybe diabetes, you go a little low down. But one important message what European guideline has given very clearly, systolic not less than 120 and diastolic not less than 70. This is alluded in our very first talk. Manoria very rightly said, Jacob phenomenon. So 120 systolic, 70 as a diastolic cutoff. There's an important message of the European guideline. So all this again depends upon the risk of the thing. As I mentioned here, if a high risk patient, then you'll get down the blood pressure less than 130/80. This is also same Indian guideline, and this is what the ISH global hypertension guideline. So essentially coming to the target of the blood pressure, it depends upon the CV risk factor and the age. So remember, general population more than less than 140/90, less than 134, established ACVD or heart failure. So coming to the third message, now after the classification, after the threshold, BP target, same figure. So remember this figure, 130/80, 140/90, risk and general population without the risk. Now coming to the last one, treatment strategy. What is the standard treatment we know today? Like, drug like ACE or ARB plus CCB, or, either single or in combination, which is probably the standard of approach, what we are doing. And that's what also been highlighted by the ISH 2020 Canadian classification. And as far as possible in the current guideline tells us single pill combination, the dual or a triple combination. And we are fortunate in India, we have got, so many double and triple combination to improve the adherence and the control of blood pressure. And Indian guideline also tells us about all the 5 group of drugs, specifically the younger individuals, beta blocker. This has been highlighted by Dr. Ponde also, and I'm a strong proponent of beta blocker. And to me, it's a nebuolol, not even bisoprolol, and that's my choice because of various reasons. So in young hypertension, it's usually the preferred drug because we have got high renin hypertension, and the older individual low renin hypertension, so CCB and diuretic, and then the combination dual or triple, and the combination is the way forward, and that's what. So coming to this treatment strategy, the summary, 5 class of drugs all can be used, but since beta blocker, newer beta blocker is not highlighted by other, but it's a strong reason for us to use, particularly the nebuolol. And then of course the younger individuals, high in hypertension and lower this one. So coming to the guideline, only guideline which there is a divergent is in the diagnosis, and that is again by the American versus the European. But rest all European, Canadian, Indian, ISH, everything are following this. But when it comes to the treatment goal is 130/80, that is a convergence. So essentially speaking, there is not much of sort of difference among the guidelines. So just to give you the take-home message, more agreement between the guideline than there is major difference. It is a way you interpret it. All guidelines strongly recommend lower BP target for high-risk patient and a similar emphasis on proper BP measurement. I would like to again highlight proper BP measurement, laboratory diagnostic, etc. are the therapeutic lifestyle, pharmacological management, proper BP measurement. Office BP is the standard BP, though Dr. Ponde said is going to be absolute. To me, ambulatory and the home BP are additive to the office. So there's no question about not taking BP. Simple, it is a thing device to do at clinic, either automated or non-automated. Never low threshold to diagnose and treat hypertension, more than 130/90, are very, very relevant in India high-risk population. And I'm very personally very, the proponent of more into the American, basically because of the high-risk population among Indians with the diabetes, metabolic syndrome, dyslipidemia, etc. maybe 130/90, whereas in the general population without the risk, you can take 140/90. Aggressive BP goal may be the difficult to achieve in all Indians, but we must make a concerted efforts to make this recommendation. Thank you very much.
And very clear message you have given that 140/90 in high risk and 130/80 in low risk.
Yeah.
Secondly, I would just like to emphasize that when there is a grade 1 or initial stages of hypertension, lifestyle modification for at least 6 months should be intensely tried, because that will be the best one. And we should focus on the comorbid diseases.
Yeah.
Just as an interesting point, not in that way, in COVID era, the mortality with hypertension and diabetes was very high. In fact, we could save very sick cardiac patients with antiplatelet thrombolytics, which we advocated from PGI initially, 2B3 inhibitors to general here in India as well as abroad. But the hypertensive patients, they died. Many patients, diabetes. So for COVID also, when hypertension is there, we should label those as a not mild COVID. They should be moderate or severe COVID if hypertension is there, and they should be treated aggressively for COVID as well as hypertension. So the mortality of COVID and hypertension will not be different as compared to the normal population. So that is at the present era, hypertension with comorbidities.
I have a question for Dr. Shetty. Some elderly patients, it is just impossible to bring down the blood pressure below 160 or below 170.
Yeah.
Sometimes they maintain a systolic blood pressure of 180. Where do these guidelines stand in these cases?
Dr. Barisha, whenever we interact with our international experts, what they mention is that even in elderly, systolic blood pressure is, important to get down to what we are talking about, the target of treatment, like in a less old patient. So it all depends upon individualizing patient, frailty of the people, whether they can tolerate, and therefore the guideline says even 140, like a 90 range, like in a particularly people beyond age of 85 and so on. But when we get the systolic blood pressure down in elderly people, possibility of diastolic also going down, which we know always there is no drug only specifically for systolic hypertension, though CCB and thiazide like diuretic chlorothalidone indapamide may be the drug which is predominantly used in elderly hypertensive, but systolic blood pressure reduction even in elderly is a recommended. And therefore, in 2017, ACC made a general statement of 130/80 for all. So point is we have to individualize, like as Dr. Sharma mentioned, in a comorbidity, whether patient can tolerate, whether there's in a postural fall and etc. But we have to see they may be also having a CAD, try to see the diastolic doesn't go less than 70, or maybe in such patients we go up to 60 also. But it's a difficult area what we have to treat. But the point I want to highlight again, try to get the systolic blood pressure to the level what we are recommending, even less than 65. And that is why, generalization for everyone, general population, like, target range, depending upon the risk, comorbidity is 130.
Thank you, Dr. Shetty.